Everybody, welcome to my YouTube channel Dr. Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to talk about a very important exam oriented topic, practice oriented topic, and one of the favorite questions of the examiners, the cavernous sinus syndrome. So we should have clear-cut concepts of cavernous sinus syndrome. So in this lecture, I'll try to have give a clear concepts of cavernous sinus syndrome. So the cavernous sinus syndrome, clarify the concepts made easy. Here we go. Cavernous sinus syndrome. But before we understand the cavernous sinus syndrome, the cranial nerves it has, the superior orbital fissure, orbital apex, we need to understand the cranial nerves which come out of the foramina of the basal skull. Only when we know these cranial nerves emerging out of the respective foramina in the basal skull, an understanding of cavernous sinus or orbital apex or superior orbital fissure will become easier. So here we go, the basal skull and the cranial nerves. This is the basal skull. We have the lesser wing of the sphenoid. Here we have the petrous part of the temporal bone, which divides the bone into three parts: the anterior cranial fossa, the middle cranial fossa, the posterior cranial fossa, and in the center we have the sella turcica. By the side of the sella turcica, extending from the superior orbital fissure till the petrous part of the temporal bone, is the cavernous sinus. But then we need to know about the other cranial nerves, because it can go and impinge on the superior orbital fissure or the orbital apex of the and affecting the optic canal. So what are all these 12 cranial nerves emerging out? We have the first cranial nerve, olfactory nerve, coming from the cribriform plate of the ethmoid bone. The second cranial nerve coming from the optic canal. The third, fourth, sixth and the first branch of the fifth nerve coming from the superior orbital fissure. We have the second branch, that is the maxillary branch of the facial nerve of the trigeminal nerve coming from the foramen rotundum. If the 3, 4, 6 and the first division of the fifth nerve only are involved, we call that as anterior cavernous sinus syndrome. But if it extends posteriorly and affects the second division of the fifth nerve, that is the maxillary division of the fifth nerve, we call that as the posterior cavernous sinus syndrome. Then we have the third nerve, the mandibular division of the fifth nerve, which comes from the foramen ovale. The mandibular division of the fifth nerve will never go into the cavernous sinus. It is only the first division, sometimes second division, when we call it as a posterior cavernous sinus syndrome. Then we have the internal auditory meatus, where the 7th and 8th cranial nerves originate, there is a syndrome known as cerebellar-pontine angle syndrome. If it gets affected, then we have the jugular foramen, from which the 9th, 10th, 11th nerves come out, which we call as jugular foramen syndrome, and the 12th nerve coming from the hypoglossal canal. But may I request your attention to be diverted, to be focused on this, the superior orbital fissure, that is the 3, 4, 6, 5th one, that is the cavernous sinus syndrome, the anterior part, and if it extends posteriorly, the second division of the fifth nerve, foramen rotundum, where we call it as a posterior cavernous sinus syndrome. If it extends into the optic canal, the second nerve also gets affected, what we call as orbital apex syndrome. I'll talk about the details soon. Right, this is an overall understanding of all the cranial nerves. Now let's start focusing on the cavernous sinus syndrome. So this is the cavernous sinus syndrome. The cavernous sinus, this is the wall, this is the main content. These are the main contents of the cavernous sinus. The cavernous sinus are the venous channels. They are the venous channels that lie on the either side of the sphenoid bone. This is the sphenoid bone. and sella turcica, further extending from the superior orbital fissure to the petrous part of the temporal bone. So here lies the cavernous sinus. So what are all the contents of the cavernous sinus? We have mainly the internal carotid artery. The internal carotid artery, and then in the wall of the cavernous sinus we have the third nerve, fourth nerve and the first division of the fifth nerve. If it extends posteriorly, the second division of the fifth nerve also can get affected when we call it as a posterior cavernous sinus syndrome. We have the sixth cranial nerve inferior lateral to the internal carotid artery. So these are the main contents. We have the sympathetic plexus going on the internal carotid artery, and therefore if they get affected, it can result in Horner syndrome. This one place is very interesting, cavernous sinus syndrome, because generally the sympathetic and parasympathetic, they don't get affected together. Either the sympathetic gets affected or the parasympathetic gets affected. Here is one condition, the cavernous sinus syndrome, where the sympathetic and parasympathetic can get affected. The parasympathetic on the third nerve can get affected and can result in the pupillary, parasympathetic causes pupillary constriction, and therefore parasympathetic, if it gets affected, there will be pupillary dilatation. The sympathetic runs on the internal carotid artery. If it gets affected, it generally causes pupillary dilatation. If it gets affected, there will be pupillary constriction. So both can get affected here. And when the internal carotid artery gets affected, person will have hemiplegia on the opposite side. So cavernous sinus syndrome will produce multiple cranial nerve palsies. The third, the fourth, the sixth and the fifth, first division, and sometimes the second division. So this is one place where you have multiple cranial nerve palsies. Third, fourth, sixth, first division of the fifth nerve, it gets affected, you call it as anterior. If the second division of the fifth nerve gets affected, you call it as a posterior cavernous sinus syndrome. Right. So these are the contents: internal carotid artery and the pericarotid sympathetic plexus. The third, fourth, sixth and fifth, first division. Second division, if it gets affected, we call that as a posterior part of the cavernous sinus syndrome. Right. And what is the etiology of cavernous sinus syndrome? What are the causes of the cavernous sinus syndrome? One, there could be tumor. Second, it could be trauma. Third, there could be inflammation. Fourth, it could be aneurysm of the internal carotid artery dilating and pushing the cranial nerves. Or it could be a carotid cavernous fistula, communication between the internal carotid artery and the cavernous sinus. It could be traumatic, or it could be spontaneous, or there could be infection when we give antibiotics. So these are all the usual causes: the tumor, trauma, infection, inflammation, carotid cavernous fistula, and the aneurysm of the internal carotid artery. But two disorders affecting the cavernous sinus we need to know. One is the carotid cavernous fistula, a communication between the internal carotid artery and the cavernous sinus, these venous channels. So what does it produce? Carotid cavernous fistula. One, it could be because of traumatic. Two, it could be spontaneous and causing a communication between the internal carotid artery and cavernous sinus. So when there is a carotid cavernous fistula, there is a direct communication going from the carotid artery into the cavernous sinus, into the venous channels. So the pressure in the venous channels begin to raise. So there is an increase in the venous pressure, which causes proptosis, bulging of the eyeballs, chemosis, swelling of the eyeballs, and there could be ocular bruit because of the carotid cavernous fistula. When we keep the stethoscope, we may hear the bruit, ocular bruit. And then when we see on the eyes, there is a characteristic corkscrew, conjunctival and scleral vessels in the eye. So you have the corkscrew vessels appearing on the conjunctiva and the sclera, episcleral vessels. This is about the carotid cavernous fistula. Another important disorder we need to know about the cavernous sinus syndrome is the Tolosa-Hunt syndrome. Tolosa-Hunt syndrome, it is an idiopathic granulations infections of the cavernous sinus causing pain and ophthalmoplegia. So there will be pain and ophthalmoplegia. It's a granulomatous inflammation but it is idiopathic. It causes pain and ophthalmoplegia. How do we diagnose? We diagnose with MRI. There would be T2 iso-intense tissue, but which gets enhanced with gadolinium. And this Tolasa-Hunt syndrome is exquisitely sensitive even to the small doses of steroids. So in fact, when there is a steroid responsive ophthalmoplegia in the cavernous sinus, we always suspect Tolasa-Hunt syndrome. So this is about the cavernous sinus. But a very important question the examiners may ask and we need to know is that how do we differentiate cavernous sinus syndrome from superior orbital fissure syndrome and from the orbital apex syndrome? Very important, very interesting. There are subtle differences but we need to know. So how do we differentiate cavernous sinus syndrome from the superior orbital fissure syndrome and from the orbital apex syndrome? In the cavernous sinus, as we all know, the third, fourth, sixth and fifth first division, second division gets affected. So the main divisions of the cranial nerve gets affected. First division of the trigeminal nerve, ophthalmic nerve. But when we come to superior orbital fissure, when it extends to the superior orbital fissure, the findings are almost similar. But one important difference between the cavernous sinus syndrome and superior orbital fissure is that here the branches of the first division of the cranial nerve, of the fifth cranial nerve gets affected. That is, the branches of the ophthalmic division of the trigeminal nerve gets affected. It is LFTSNIA. So these are the branches which get affected. The lacrimal division of the ophthalmic branch of the trigeminal nerve, the frontal branch of the V1, T is for trochlear fourth nerve, S is for superior division of the ocular third nerve, and I is for the inferior division of the ocular nerve, N is for the nasociliary branch, and A is for abducent nerve. So now how do we remember all these branches? We can remember it by having an acronym. The acronym is LFT. LFT is for liver function test, SIN, SIN, and A for antonym. We have synonyms, we have antonyms. So LFT, SIN and A we write it, but then A is for antonym. So what we do is that when we write SIN, we interchange I and N. So instead of SIN, we write SNI. So easy to remember, LFT, SIN, A, antonym, so we change I and N. If we remember this, we'll be able to remember this. LFT, SNIA. L for lacrimal branch, F for frontal branch, T for trochlear nerve, S for superior division of the third nerve, N for the nasociliary branch of the first division, and I for the inferior division of the third nerve, A for abducent nerve. So the subtle difference between the superior orbital fissure and the cavernous sinus is that cavernous sinus, fifth division, the main division, the first division gets affected, ophthalmic division, but here the branches of the first division, namely the L, F and N gets affected. That is the subtle difference between the cavernous sinus and superior orbital fissure. And then finally it can extend beyond the superior orbital fissure and can go and affect the optic canal. So the second nerve also gets affected. So this is known as orbital apex syndrome. So what is orbital apex syndrome? The superior orbital fissure plus the optic canal. The superior orbital fissure namely the 3, 4, 6, V1 and the optic canal is the second cranial nerve. So when the second cranial nerve gets affected along with the superior orbital fissure contents, we call that as an orbital apex syndrome. So mainly the second nerve is also involved in the orbital apex syndrome. So when the second nerve gets affected, we can have a decrease in visual acuity, the rapid afferent pupillary defect, we can have visual field defects. When the third, fourth, sixth nerves get affected, we have the ophthalmoplegia, and then the first division of the fifth nerve gets affected, we have sensory deficits. So very important point is that how do we differentiate cavernous sinus syndrome from superior orbital fissure from the orbital apex syndrome? Cavernous sinus, it is the 3, 4, 6 cranial nerves and first division of the fifth nerve, sometimes second division of the fifth nerve. Whereas superior orbital fissure, almost the same contents, but instead of just the first division of the trigeminal nerve, the branches of the trigeminal nerve, the first division gets affected, namely lacrimal, frontal, nasociliary branches. The orbital apex syndrome is nothing but the superior orbital fissure plus the optic canal involvement. Optic canal, there's a second nerve. So we have the contents of the superior orbital fissure and the second nerve getting affected, which we call it as an orbital apex syndrome. So when there is a 3, 4, 6, 5 cranial nerve palsies, ophthalmoplegia plus the fifth nerve being affected, we should always suspect cavernous sinus syndrome, and we should know all these causes of the cavernous sinus syndrome because some are easily treatable. For example, Tolasa-Hunt syndrome, we give steroids, exquisitely sensitive. If there is infection, we can give antibiotics. If there is carotid cavernous fistula, we can intervene surgically. So one of the treatable causes of ophthalmoplegia, and very interesting and exciting place where all the cranial nerves get affected, where sympathetic and parasympathetic can get affected together, where internal carotid artery can get affected and can give rise to hemiplegia. So much of information is present in the small area of the cavernous sinus, and therefore it becomes very, very important and essential for us to understand this cavernous sinus syndrome. I hope you have enjoyed listening to my lecture as much as I have enjoyed delivering it. If you have any suggestions or comments, please post on my YouTube channel. I'll be happy to respond to your comments. But don't forget to like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.